Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey. Insights that matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Healthy Insights That Matter. In 2023, approximately 153,020 individuals were diagnosed with colorectal cancer, and an estimated 52,550 died from this disease, including nearly 20,000 cases and 3,750 deaths in individuals who were younger than the age of 50. In this month's podcast, I am joined by colorectal surgeon Dr. Ada Graham, an assistant professor of surgery at the Johns Hopkins University School of Medicine. She practices in our National Capital Region. So welcome, Dr. Graham, and thank you for joining us today.
Thank you so much for having me. It's a real pleasure to be here.
So this is a really important subject and one that people usually don't like to talk about because nobody is interested in discussing that part of their body, unfortunately. And yet it's an area that we need to increase focus on. And it no longer is a situation where we just have to worry about it for people that are older. We also now need to worry about people that, in fact, are younger. For those listening to our podcast right now, colorectal cancer, that term is really an umbrella term. Can you describe for me what are the different types of cancers that are included in that diagnosis?
Colorectal cancer is most commonly used for the type of cancer that's called adenocarcinoma. And that's the vast majority of colon and rectal cancer. And it arises from the cells that are on the lining of the colon and the rectum. Now, there are some subtypes of that, such as mucinous, but that's typically what we're talking about when we refer to colorectal cancer. We're talking about adenocarcinoma. However, there are other cancers that can also arise in the colon. These are much less common, but they're treated quite differently than adenocarcinoma. And these include cancers such as carcinoid tumor, which can be almost anywhere in the GI tract, a gastrointestinal stromal tumor, sarcomas, which can be almost anywhere in the body, and lymphomas. We oftentimes think of those in the lymph nodes, but they can also arise in the colon and rectum.
When we're thinking about the colon and rectum, this may sound like a silly question, but I can assure you there are people that would be interested in hearing the answer. How do we define the colon? And how do we define the rectum? And how do we define the anus? Because these are all anatomically connected, but they're not just one thing.
That's a great question. So we sort of say the large intestine for everything that's beyond the small intestine. And there's a valve basically where the small intestine feeds into the large intestine. And that's the start of the colon. The appendix is right there. And then that goes around in what looks like a giant question mark if you're looking at your body. But the very bottom part, that's about the bottom 15 centimeters, is typically described as the rectum. Officially, it is what we call where we see the splaying of the Taenia coli, which basically means if you look on the outside of it, the wall of the colon gets smooth instead of having little wrinkles. But that is where the official what is colon versus rectum is, but it's not a clear margin. The reason why it's important for discussion is oftentimes the treatment for rectal cancer can be different than the treatment for colon cancer. There's a lot of overlap, but that's why it's important. It's very hard to tell on the inside of the colon if you are in the rectum, which is that part, or the bottom part of the colon, which is known as the sigmoid. It's something that you can see more easily on the outside. When we're talking about the anus, there's a lot of different definitions for it, but we're usually talking about the anal canal, and that's on average about 4 centimeters long. And that is where the muscles come together for the anal sphincter. And a sphincter just means a circular muscle that acts like a spigot. So it squeezes tight to keep you continent. Basically, you only have a bowel movement when you want to, and relaxes when you don't. The reason why that is important is there is a distinction between the types of cancers we get in the anus, which is what is normally described separately as anal cancer and the cancers that we lump together as colon and rectal cancer. And the reason why that's important is anal cancers, the majority of them come from a different cell type. It's called, instead of adenocarcinoma, we describe them as squamous cell carcinoma. And the treatment method for it is completely different. It usually does not require surgery and is started with upfront chemotherapy and radiation. But that's the general gestalt.
That's very helpful because I think that in general, people don't know what all is down there. Even if they've had a screening done and had a colonoscopy, they were asleep. No one was saying, okay, I've just traveled through the anal canal. I'm now going up, because they're sleeping for that very short few minutes that procedure is being done. Why is the frequency of colorectal cancer increasing among adults that are under the age of 50? Because that's relatively new in the last couple of years.
That's a great question, and I wish I knew. I wish all of us knew. Many of the risk factors that we see for colon and rectal cancer involve things like sedentary lifestyle, obesity, being overweight, heavy alcohol use, high-fat diets or diets high in processed meats. However, those normally take years to accumulate gradual damage to the DNA that leads to cancer. But there's a lot of active research going on trying to figure out why cancer and colon and rectal cancer in particular is rising at an early age. So that work is still being done. But one of the things that's really important about that is that in the last few years, we've recently dropped the recommended age for your first colonoscopy for people who do not have an increased risk. So these are not people who have family members with colon cancer, but the first colonoscopy for screening should be at age 45 now, not 50. And that's been approved by the US Task Force, the American Society of Colon and Rectal Surgeons, and the Gastroenterology Societies. And we are all in agreement that the first screening should now be at age 45 to catch these cancers earlier, because colon cancer caught early, on average, has a very good prognosis.
And that is the purpose of that screening, so that we can get in there and find a polyp that has already gotten mischievous and gone bad, or one that might want to later, right? It's so rare in the cancer field that we're able to actually say we can prevent this. It's not something that happens with most other cancers, for sure. So can you describe to me some of the early warning signs that someone might be dealing with colorectal cancer?
The majority of colon cancers that are found on colonoscopy are asymptomatic. So that means you're not having any symptoms. And that's why it's so important to do your screenings. However, signs that should make you present to your primary care provider are any type of rectal bleeding, okay? It's very important to never just chalk it up as hemorrhoids. I can't tell you the number of patients I've seen who have just for years said, oh, I just have some hemorrhoids. It's fine. And what they really have is colon cancer that's gotten quite large. So any rectal bleeding needs to be evaluated. Other things are vague abdominal pain, which is a tricky diagnosis because it's, well, vague. Weight loss that is unintentional is always a red flag. This isn't when you've gone on a diet or made exercise changes and you were trying to lose weight. This is the, oh, I've lost 20 pounds and I wasn't even trying. While that might be a fun surprise for physicians, that really raises the concern that there may be a malignancy, not just a colon and rectal malignancy, but other types of cancer. That's one of the classic pieces of information we find when we're doing a history for somebody that has a known diagnosis. I had someone just last month that I treated for colon cancer who had had a large previous surgery and had been in rehab getting stronger. And over that time period had lost 30 pounds. And she had just chalked it up to, oh, I'm doing rehab. But there was actually a cancer there that needed to be taken care of.
Wow. What would you say is the most effective and accurate way to screen for colorectal cancer? And how often should someone be getting that screening done?
The gold standard for screening for colon and rectal cancer is a colonoscopy. And the reason why is it is the only method that is both diagnostic and therapeutic. All of the other methods, such as Cologuard, which is DNA testing, or FIT test, or a CT colonoscopy, do not allow you to remove polyps. They also do not allow you to get a tissue biopsy to see if anything is going on. Now, the US task force has stated that a FIT test annually is considered acceptable, followed by a colonoscopy if it is positive, or a DNA test, which is the Cologuard, every 1 to 3 years, a CT colonoscopy every 5 years, a flexible sigmoidoscopy, which is the bottom scope, every 5 years. And then we typically recommend screening age 45 to 75. Now that regimen of there are multiple options is only for people at low risk. If you have a family member who has had colon or rectal cancer, in particular a first-degree family member, or you have ever had a colonoscopy that had polyps in it, those other screening methods that are not a colonoscopy are not a good option for you. They're better than no screening, but they are not the preferred screening method. And I would say that most colon and rectal surgeons and most gastroenterologists would still recommend a colonoscopy because it allows us to both remove polyps and identify cancers.
So I've been seeing Cologuard advertised on television. So they're doing direct to consumer advertising. What is the background on that test? What is it measuring and how accurate does it even measure whatever it is measuring?
What Cologuard is measuring, unlike the earlier test, which just looks for blood in your stool, the Cologuard is looking for abnormal DNA. And if you are looking for cancer, the large studies that they did, which have supported Cologuard, has had a sensitivity. That means if there is a cancer, what is the chance we will find it with a Cologuard? Of about 92 to 100%. On average, we typically say about 92 to 94. And then the other question with that is specificity. Specificity is if the test is positive, what are the odds that it is actually cancer? So we sometimes call those true positives versus false positives. And the specificity is about 87%. So if somebody has a positive Cologuard, the next step is a colonoscopy. And then we're looking to see, is there a cancer there? Now, one of the things that Cologuard does not do as well is finding large polyps that may be precancerous. For those are called adenomas. Those are precancerous polyps. And based on studies looking at Cologuard for those, if a polyp is between 1 and 2 centimeters, it only finds about half of them. If they're 2 to 3 centimeters, they find about 2/3. And if they're greater than 3 centimeters, so around that age, so those are quite large, they're finding about 70 to 80%. So that's a little bit of a downside because it's doing a pretty good job of finding cancer. It's not doing as good a job of finding those precancerous polyps. It's by far much better than not getting screened at all. It is a huge improvement above that, but it's not as good for polyps, which is why we really strongly encourage any patient who's had a history of polyps to make sure, unless they have a strong reason or indication not to have a colonoscopy, to have a colonoscopy instead of Cologuard.
That makes very good sense. Let's talk a little bit about heredity. You mentioned about family history and particularly individuals that may have a first-degree relative, so mom, dad, sibling, daughter, son. Can you share some information with us about that and the potential genetic mutation link that there may be?
So there are multiple genetic syndromes that can cause cancer, not just colon cancer, but the same mutation can cause many different types of cancer. And so the two categories that we most frequently talk about when we're talking about colon cancer, the first one is called familial adenomatous polyposis. It is an autosomal dominant, which means you only need one copy from one of your parents to have it. And these patients tend to have hundreds of polyps in their colon by the time they're 20. They will have nearly a 100% chance of colon cancer by their 40s and 50s if they don't have their colon removed. This type of family history is normally fairly obvious as long as a patient is aware of what their family history is. If people are not aware of who their genetic parents are, that's something they may not be aware of. But for families that have what we call FAP, that's the acronym, it's normally something they're very aware of. The second category, and this is something that has gotten a lot more interest recently, is something called HNPCC, which is a mouthful of an acronym, but it means hereditary non-polyposis. That means inherited, not with polyps, colon cancer. And this accounts for about 2 to 3% of all colon cancers, and it's found in about 1 in 500 people. This is also an autosomal dominant mutation, or it's actually a family of mutations. So that means, again, that you just need one copy inherited from a parent. And this has to do with mismatch repair genes. And what that basically means is whenever a cell duplicates, basically a proofreader goes through to make sure that that copying of the DNA went smoothly and there's not an error. When there's an error in that mismatch repair gene, I think of it as like getting a bad photocopy. And then you make a photocopy of the photocopy, and then a photocopy of the photocopy of the photocopy, and things start looking real fuzzy and you can't see anything. And so there are 4 genes that we largely look at for this. They include MLH1, MSH6, MSH2, and PMS2. We look for those in anybody who's had cancer earlier than the age of 50, and we actually have guidelines that make us initially look for this disease. They're called the Bethesda guidelines. The earlier ones used to be called the Amsterdam criteria, but they basically are if you've had colon cancer before the age of 50, if you have another cancer at the same time that is in the family of cancers that could be caused by these mutations, and those include endometrial cancer, stomach cancer, ovarian cancer, pancreatic cancer, cancers of the ureter, that's the connection between the kidney and the bladder, cancers in the biliary tree, which is what connects the liver to the duodenum and the intestines, or any type of cancer in the small intestine. We also look for it in anybody who has a mutation in the polyp that could have arisen from one of these. And what that basically means is anytime we do a colonoscopy and we find a cancer, we run some tests on it for specific mutations, these 4 mutations I talked about. Now, most of the time, if we are diagnosing this in a patient without that family history and they have that mutation, we describe that as a sporadic mutation. What that means is that it was just the cells in the colon that had that one mutation, which is what caused the cancer. That's different than what's described as a germline mutation. That means you inherited this mutation from a parent, and every single cell in your body has this mutation. So that's the difference between sporadic, which means the mutation just happened in the cells that have cancer, and germline, which means every cell in your body has it. And so this is why we look for it. And now anytime we do a biopsy and we find cancer, we run those tests on those 4 genes. And if any of those genes come back, we say, oh, so the cancer has this mutation. Now we need to check if all the other cells may have that mutation, because that would let us know, oh, this might be germline, so something that could be inherited. Other things that we think about for it is anyone who has 2 or more first or second degree relatives diagnosed with colon or rectal cancer, or another one of those tumors that are related. So if you have colon or rectal cancer and you have 2 family members who are first or second degree relatives, that now makes 3 of you, it's worth doing the testing. And this is something that colon and rectal surgeons and gastroenterologists are very aware of, especially with the odds of this mutation being about 1 in 500 that you have one of the mutations. So these tests are often done pretty routinely, and it's definitely something that I check for as part of what pathology has been done and what testing's been done.
Is that type of a test covered by a patient's health insurance?
It usually is. because it's considered the standard of care. Now, if we're doing germline testing, then you would need an indication for it. But if you have the mutation, then it is usually covered.
Got it. In looking from a treatment perspective, and let's say this is for early stage colon cancer, is surgery always a portion of that treatment?
It is almost always a portion of the treatment. There are some cases where you just have cancer in the very tip of a polyp that they were able to remove completely by colonoscopy, and we looked at the depth of the invasion. And the reason why the depth of the invasion into what we call the stalk of the polyp, or how deep it goes into the wall, is important because it helps predict the odds that the cancer that was just in the polyp may have also spread to the lymph nodes. And knowing that the cancer spread to the lymph nodes is very important for helping us determine treatment. Now, there are some cases, not for colon cancer, but for rectal cancer, where potentially, even if you have a larger tumor, it may be able to treat it without surgery. But I always let people know that even if we're doing surgery, which people justifiably know that that's a big deal, that we typically can do this now minimally invasively with much smaller incisions and a shorter recovery time. There are definitely cases where we need to do the old school open incision, but in general, the majority of these we can do with minimally invasive techniques with incisions that are a centimeter to an inch or two wide. I always tell my patients that I can operate through a 1/2-inch incision. The only time I need one's a little bit bigger is I need one incision that's big enough to get the tumor out. So if your tumor is 6 centimeters, I need one incision that is 6 centimeters for me to get it out.
Yes. And for our listeners, 2.5 centimeters equals 1 inch if they're trying to figure out the measurement correlation. What types of tests would a patient need to be doing before their treatment as well as after they've had their treatment?
So whenever someone is diagnosed with colon cancer, the first thing that they need to do is first they should see a colon and rectal surgeon, and we are going to request a CT scan of the chest, of the abdomen, and the pelvis. And the reason why we do that is we are checking to make sure that there is no evidence that the tumor that has been found on the colonoscopy has spread to other organs. And the reason why that's important is I think whenever we're doing a test, it needs to be giving a piece of information that will change what we do. And the reason why we do a CT scan before we go to the operating room potentially to cut out cancer is that if there is evidence that there is cancer in the liver or the lungs, we may need to do something else before treating the cancer just in the colon, such as chemotherapy to shrink it. Or we may need to do a biopsy of that lung or liver lesion to say, is this cancer? Because if it is, colon cancer that has spread to the liver or the lung may still be treatable with surgery. If we can get all of it out, if we call it resectable, which means it is able to be cut out, if we have a small liver lesion and a colon cancer, we could potentially cut both of those out. So that's why that test is important. So we are looking for, is there spread of this cancer beyond the colon? The other test that we do is something called a CEA test. It's a blood test that can be elevated in colon cancer. Now, you can have colon cancer and have a normal CEA level, but if it is elevated, then it is a useful test to know so that after we've treated your cancer, we'll retest it. And if it's low, we say, great, the cancer is out, and we can follow it so that if that number started climbing back up, that could raise the suspicion that we need to go looking again for a chance that the cancer may have come back. But those are the tests that we do before surgery. And then we want to make sure anytime we're taking someone to surgery that we have what we call optimized. So I would like you as healthy as possible from your heart and your lungs so that your body is as ready as possible to undergo surgery.
And how about after treatment is completed? How often, say, would someone be getting a colonoscopy post-treatment?
So it depends a little bit on what stage the cancer is. And stage is defined basically by 3 things. The first is how deep did the tumor go into the wall of the colon? And that's typically T1 to T4. Has it spread to the lymph nodes? And then has it spread to other organs? In general, the basic rule for colon cancer is stage 1 and stage 2 means that it is in the colon wall but has not spread to the lymph nodes. Stage 3 means it has spread to the lymph nodes but not other organs. And stage 4 means it is spread to other organs. So for patients with stage 2 and stage 3, and then also stage 4, but those patients are also getting more advanced treatment, we typically recommend a colonoscopy 1 year after surgery. Then if that colonoscopy is clean, so no polyps, no lesions, we recommend a colonoscopy 3 years after that one. And if that one is clean, they go to an every 5-year screening for the rest of their screening life. They never go back to the baseline every 10 years that you may have if you have never had cancer and have never had anything on your colonoscopy. The guidelines for stage 1, which is a much earlier cancer, is a little bit more in the air if you look at what we discuss, and that's because it is a much lower risk of coming back. But most of us would still do a colonoscopy at 1 year to evaluate.
Let's talk a little bit more about the colonoscopy itself. I think that, one of our challenges is the bowel prep. I haven't found anyone, including myself, that enjoys doing the bowel prep. And I've had a friend of mine that said, I never want to get one of these again because I don't know who is in the room looking up my rear end, which was an interesting comment that she made to me. I think if we can talk about why is this bowel prep so important so that people don't try to not take the whole bowel prep and say, I think I've done enough, as well as who is in that room observing this or actually doing the procedure.
So the bowel prep is really important because the camera on a colonoscopy is really good, but I can't see through poop. And we are looking for things as small as 1/4 of an inch wide. And so if you think of stool as brown and opaque, you can't see through it. If it's there, it really increases the risk that I'm going to miss something because the walls are coated. And I always feel really crummy waking up a patient after a colonoscopy and say, guess what? Instead of us having to wait 10 years, you need one in the next year again. And so that's always the worst. I know for me, and I know for my patients, they'd rather do it once and get a good exam than have to do it again. Now, I can wash out some of the stool while I'm in there, but if it's just covered in stool, you can't see anything. And we're looking for really small lesions. And so the cleaner it is, one, the more likely we are to find the polyps that we can take out before they become a problem. So that's why that bowel prep is so important. And so if you have ever had a colonoscopy and somebody told you, oh, the prep wasn't great, when you go to a provider again for a colonoscopy, please let them know that, because there are things that we can do to modify it. Unfortunately, it may mean an extra day of drinking juices and liquids, but I really want that prep to be good so we can see what we need to see, and I don't have to tell you to come back in the next year. Now, in terms of who's going to be in the room for a colonoscopy, well, the first person who will always be there is the person doing the colonoscopy. So a gastroenterologist or a colon and rectal surgeon will be in the room, and they will be doing the whole scope. In most situations, there will also be an anesthesia provider. That would either be an anesthesiologist or a certified nurse anesthetist. And their job is to keep you comfortable and safe during the colonoscopy. There will also then be at least one other person in the room, and oftentimes two. One is the nurse who is documenting every step of what we're doing, and that might be we do a timeout. And that's basically a pause where we make sure everyone knows what we're doing. We've got the correct patient. We have all the equipment we need. We all agree that we're ready and it is safe to go ahead. And the other person we have is what we call the technician, because in order to remove polyps or tattoo an area so that we can identify that part of the colon, not just on the inside of the colon, but on the outside, I need them getting equipment and handing it to me because my hand is on the colonoscope the entire case. So I need someone to hand me the equipment if I need to put it down into the colonoscope. So there are typically 4 people in a room during the case. What is not typical are random people coming in and out. The door is shut, the lights are down, It is just the people who are in the room to do the procedure and to help keep you safe.
That's very well stated. And I think that will relieve a lot of people's minds because it's the loss of control that I think some individuals have trouble with. And knowing who is in there and that they are needed to be in there, they all have a purpose and a task at hand can ease some people's minds. Are there any common side effects that a patient might experience while they're undergoing treatment? For example, if they're having surgery, what might they expect after that surgery? If they're doing chemotherapy, what might they experience during that?
For surgery, the most common side effects people have is one is soreness at the incisions. I have to get into your abdomen somehow. And so those incisions are going to hurt. But the smaller the incisions we can make, typically the less they hurt. Sometimes people can get a little bit bloated after surgery, and that's because I have to move the intestines around to get to the piece of colon that I need to remove. So sometimes people can have a couple of days where they feel a little backed up with gas, but that's the most common. Occasionally coming out of anesthesia, patients can feel nausea, and so that can be an issue. Those are the main things we think about. Most patients feel pretty tired for the first few weeks after surgery. And that's just because although they were asleep, their body was doing a lot of work while they were in the operating room. And it's just their body building back up the strength and energy from recovering from surgery. Now, in terms of chemotherapy, it depends on which regimen you're on. And I would defer a lot of the details of this to my medical oncologist because most chemotherapy regimens for colon cancer are given by a medical oncologist. But some of the side effects you may see with the more common treatment protocols for colon cancer involve neuropathy, that's some numbness at the end of your fingers. Sometimes people can get flushing or a skin rash. Diarrhea is very common. And that's because cancer treatment regimens, chemotherapy is typically trying to hit cells that are multiplying quickly because cancer cells are multiplying quickly. That's why they're a problem. They're growing. And other cells in our body also multiply quickly. And one of those are the lining cells to your gut, so you can get diarrhea. Now, one of the side effects that you usually do not get from colon cancer chemotherapy is hair loss. It is not common on most regimens for colon cancer for people to lose their hair. That is not a common side effect.
One of the things that I ask patients who have been newly diagnosed with some type of cancer is to tell me what milestones are coming up over the next few months, such as a son's graduation, a daughter's wedding, that are important for us to preserve so we can figure out the treatment plan in a way that the patient can feel well on that big day. We certainly wouldn't want a bride's dad dealing with diarrhea as he's walking her down the aisle, right? But if the patient doesn't share with us what these milestones are, they're so distressed and upset that they've been diagnosed with cancer that they'll say, those milestones don't matter anymore. Please just get this cancer gone. And I always say later, these milestones will matter a whole lot, not just to you, but to the rest of your family. So I mention that so that our listeners can remember that as well, that we really do need to know more about them beyond their pathology so that we can dovetail some of these significant milestones into that treatment planning process. I'm excited to hear about laparoscopic surgical procedures. I'm curious to know, do you inflate the abdomen to see more clearly where everything is?
Yes, so we can do minimally invasively, can either be laparoscopic or robotic. Both of them are minimally invasive, and we do inflate the abdomen. And that means you have to be able to undergo general anesthesia because the anesthesiologist has to be able to control your breathing, because when we inflate the abdomen, it pushes against the diaphragm, which is the muscle between the abdomen and the chest. And that does allow us to have more space so that we can see, because normally our abdomen's pretty flat and there's not a lot of extra room in there. And this allows us to get a top-down view of the area. Now, some patients, if they have had multiple abdominal surgeries previously, such as they've been in a really bad motor vehicle collision, or they had an injury during service in the military or something like that, they may not be able to have surgery in a minimally invasive manner. We can typically attempt, but sometimes there's too much scar tissue that we're not able to inflate that abdomen because we have to be able to see in order to put the instruments in that we work with. But most patients can be done in a minimally invasive manner.
While you're doing that procedure, do you also by chance look at other things in the abdominal cavity? For example, the patient's appendix. Would you take out their appendix?
Well, we would take it out if there was a problem with it. Whenever we do a consent, we say we're going in to treat this problem. And if there's something that is an issue while we're in there, we will address it. And we definitely look carefully while we're in the abdomen to make sure that we don't see any evidence of cancer spread that might have been missed on the imaging. But we do not typically go on a hunt for things that are not there. So for example, if I'm doing surgery in your abdomen, I'm not going to go up and make an incision in your chest to take a look at your lungs. That would not be appropriate. But in the part of the body that I am in, I will take a close look at everything.
Okay, so that perhaps would also include a patient's gallbladder?
You will. Sometimes it's not always visible if there's scarring back there. And we wouldn't remove it unless there was evidence that it was like really badly diseased. And that's because whenever you're doing a procedure, you want the patient, or I want the patient, to know what I'm doing, because it's very hard to have a discussion once the patient's asleep and there's a breathing tube in. And so I don't want them to wake up and be like, oh yeah, I did the thing we talked about. And oh, by the way, I did all these other things. No, if it's something that we need to do to keep the patient safe, I always tell the patient the most important thing whenever I'm taking any patient to the operating room is keeping them safe. So we give this sort of funny example that there's an earthquake in the middle of the case. So we stop, we wait till the concrete's in, and then we get back to doing the surgery. But safety is number one. Effective, which means getting out the cancer, is number two. But we've got to keep you safe. So if I need to do anything that's quote unquote extra to keep you safe, yes, we will do that. But I would not go in and do a procedure that we had not talked about unless I really thought that that patient needed it to be safe, and safe in that immediate moment. We try very hard to make sure patients are aware of what we're going to do because there's a lot of trust in us. They are asleep. Just like you had said for the colonoscopy, they feel sometimes a lack of control. I want to make sure that my patients know why I'm doing this to their body and what these steps are, so that there are not surprises when they wake up about what we did, because it lines up with what we had discussed in clinic, and they know the decision-making process that I was going through in my head while we were in the operating room.
Tell me about clinical trials that are underway.
So there are a lot. It has been more on rectal cancer in terms of different regimens. There was recently, do you do chemotherapy with radiation before surgery, or can you just do one or the other? A lot of the treatment and the trials now are looking at different regimens for more advanced colon cancer and more advanced rectal cancer. One of the things that has come up, I would say, in the last 10 to 15 years is for some patients with rectal cancer, so cancer in the bottom part of the colon, we may be able to treat this without surgery at all. There are some patients that have what we call a complete response to chemotherapy and radiation. Now they have to have a lot of colonoscopies afterwards to make sure everything that has become gone stays gone. But that's something that's an active area. But for colon cancer, it is definitely, if you have cancer right now, the treatment is, we need to cut that part out.
If we were to look at a colorectal cancer survivor, are there any restrictions of what they can't do physically, say 3-5 years after their treatment's all done?
No, absolutely not. One of the reasons I really like treating colon cancer is, for all that we do a big surgery inside the abdomen, people's quality of life after treatment and after surgery for colon or rectal cancer is usually very good. About the only side effect sometimes people may say is, oh, doc, I used to have maybe one bowel movement a day and now I have two. It would not be common to say, oh, doctor, I used to have one bowel movement, now I have six. That can happen from other causes, but not usually from the surgery itself for colon cancer. Activity-wise, the colon's main job is to absorb water. The small intestine's main job is to absorb nutrients. So if I take out part of your colon, your bowel movements may be a little bit softer, but you should still be able to absorb all the nutrients that you need to get the energy and the vitamins and the minerals you need from food. With the minimally invasive techniques for surgery, so laparoscopic and robotically, the odds of developing a hernia, and a hernia just means the incision, so the little cut we made to get into the abdomen didn't heal or seal exactly tight, and so you get a little bit of a bulge. That's one of the complications you can have after any type of surgery in the abdomen. And that hernia can be uncomfortable. It can be repaired surgically, but with minimally invasive techniques, the odds of that happening are much lower.
As I've been listening to all of your really well-stated answers, I'm thinking about the game Jeopardy! And if they have a colorectal cancer column, I think our listeners might be able to win a lot of money in having listened to you today and giving us really a thorough understanding of this type of cancer and how it's managed, and even right down to the DNA of it. I also suspect that most of our listeners were unaware of the fact that you need to tattoo the spot where you took something out when you were doing that colonoscopy. So for many of our listeners that are women, I'm sure that they've encountered other people and said, oh my gosh, she got a tattoo on her back or her neck or her whatever, and then would respond and say, well, I'm never getting a tattoo, when in fact, she might have one right now. It just isn't visible except to you. And I want to end in telling you something I had attempted to do with the American Cancer Society a few years back. I had gotten a national award from them, and it was about 2 weeks later when I formally wrote to them, thanking them for this award, and gave them some recommendations of some slogans I thought would inspire people to go ahead and do a colonoscopy. And so here were the slogans that I sent them. Just don't sit on it, get it checked. Invest in your bottom line, get a colonoscopy. And the third one was, let me give you the straight poop about colorectal cancer. Unfortunately, the response I got back from their president said I was a little too edgy and they would not be able to use these at all, which I still think they made a mistake in not using them. So it's something that I tell my patients and say, you go inspire somebody else to also do the right thing and get their colonoscopy. I was giving a survivorship presentation a few years ago in Baltimore. I'm a 31-year cancer survivor. One of the physicians that was there was also on this panel and was a cancer survivor, and he was a survivor of lymphoma. When he finished telling us all about his journey with that, I noticed that he was in a military uniform with a lot of brass on him. When they were asking questions, I asked him a question. I said, can you tell us what rank you are? I see that you're in the Navy. And he says, yes, I'm a rear admiral. And I said, then don't you think you should have colorectal cancer instead of lymphoma? Everybody laughed but him. I thought, I must be too edgy.
Well, we really stress the colonoscopy. Sometimes I have patients who don't want to get a colonoscopy because they're afraid of what they'll find. And what I try to reassure patients is that the reason we do colonoscopies is we can find it in a lot of cases very early when it is treatable with a good quality of life afterwards and a low chance of coming back. So for example, if we find the cancer before it has spread to lymph nodes, about 90% of patients at 5 years are cancer-free, living their life. If it's spread to lymph nodes, so that's that stage 3, so already pretty advanced, it's been there for a while, it's about 70%. And that really drops off if we don't do screening and it gets found when it's spread to other organs. That survival drops down to about 13%. So the reason why colonoscopies are so important is that there's this very long window. Most colon cancers grow slowly, starting from a polyp over several years. And so if we can catch it in that window, the odds that you're going to be doing those important family events, the walking your child down the aisle or doing that cross-country road trip 15 years from now are very possible. And that's why we do the screening for this, not to find a diagnosis and then tell you there is no hope, but to find a diagnosis and say, here's how we're going to beat it.
That's wonderful. Thank you so much for joining us today and really giving us a bird's eye view as to what colorectal cancer is, how it's diagnosed, most importantly, though, how it can be prevented from being diagnosed and what its treatment is, and that we've come a long way in the last couple of decades as to how we can manage it. And I'm going to make another pun, get it behind us instead of still being in front of us. So thank you, Dr. Graham, and I want to thank everyone for listening to this podcast. We hope you will join us next month for another educational and information podcast featuring another Johns Hopkins Medicine expert. To learn more about important women's health topics, attend A Woman's Journey next in person from 9 to 11:30 a.m. on Friday, May 17th at the Bethesda North Marriott Hotel and conference room that's located in Rockville, Maryland. To receive information about this event and other women's health content, please visit the A Woman's Journey website at hopkinsmedicine.org/A Woman's Journey to sign up for our monthly e-letter, read about upcoming podcasts and programs, and to sign up for our upcoming free Conversations That Matter webcasts. Again, thank you so much.
Thank you so much for having me. It's been a pleasure.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey acknowledges unrestricted educational support for our podcast, Healthy Insights That Matter from Astellas. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.